Good? All right. We're going to get the Longevity Science Caucus briefing underway. Thank you all so much for joining us today. I'm Dylan Livingston. I'm the founder and CEO of the Alliance for Longevity Initiatives. We're honored to begin with opening remarks from three champions of aging research policy. Congressman Gus Bilirakis. We could give it up. Yeah, let's give it up. Yeah. Absolutely. Congressman Paul Tonko, who I think is also here, yeah. And CMS Administrator Dr. Mehmet Oz, who I think is on his way. Their leadership on Capitol Hill and in public spheres has been instrumental in elevating longevity science as a national priority. After their remarks, we'll transition to a expert panel on the latest breakthroughs in policy and longevity science with Dr. Eric Verdin, Dr. Matt Kaeberlein, and Dr. Mike Roizen. So without further ado, please join me in welcoming Congressman Gus Bilirakis.
Thank you very much. I really appreciate it. I'm really excited about this caucus. Who doesn't want to live longer, right? As long as we have a quality of life is so very important as well. So this is really fascinating stuff. So good morning, and thank you for inviting me to be here today for the Longevity Science Congressional Caucus Briefing. And I want to introduce Leanne, who's my new healthcare LA. She's doing an outstanding job so far. So raise your hand, Leanne. Thank you. So I'm proud to once again be co-chairing this important caucus with my good friend Paul Tonko. Where's Paul? He's here somewhere, isn't he?
I'll be here shortly.
Okay. Yeah, he does a great job on energy and commerce. I told him the other day, and he said the same thing about me. We're not show horses, we're work horses. And that's true. And we need more of those in D.C. So I'm looking forward to hearing from your esteemed panelists today. Of course, I'm honored to be joined by CMS Administrator Dr. Oz. And I know there are others. Dr. Verdin's going to speak, Dr. Roizen, and Dr. Kaeberlein. I hope I pronounced that right. I want to thank the Alliance for Longevity Initiatives for their great work to advance longevity science and to raise awareness to the promise that this research and development can bring in Americans to, the healthcare system that we're looking for. Longevity science is an important initiative because it holds the potential to significantly improve the quality of life for Americans. And that's what we're seeking, quality of life and longevity. By unlocking the biological mechanisms being aging, scientists can develop interventions that delay or even reverse age-related diseases, such as Alzheimer's, heart disease, Parkinson's, and cancer. So I have family members who have Alzheimer's and Parkinson's and, of course, heart disease. So life expectancy is an often used metric in the field of medicine and public health. And unfortunately, in recent years, it has gone down in the United States to its lowest level in many years. We have to reverse that, folks. We really do. Dr. Oz, nice to see you. Nice to see you. He's a busy guy, and we appreciate your sacrifice. We appreciate all your sacrifice on behalf of the country. We really do. And you're making a tremendous sacrifice. I know you'll do a great job under this president. Thank you. So we need to invest in ways to change that trajectory, and I'm hopeful the research that the aging science community is doing will unlock the keys to doing so. Thankfully, biotechnology companies are conducting significant research and development efforts to apply this science to potential treatments that delay the onset of these diseases. That's really exciting. If we can effectively treat against the aging process, this could lead to significant breakthroughs in how we approach disease states, and again, progression of age-related conditions. So I'm hopeful with a combination of the private sector, that's what it takes, and the public research dollars, we can make progress that will improve patients' outcomes and help people live better and longer lives. We do have to think outside the box. So, longevity science also directly aligns with the goals of the Make America Healthy Again movement. By promoting long-term, that's right, by promoting long-term well-being and addressing preventable diseases that disproportionately affect older populations. As the movement advocates for a healthier, more vibrant society, longevity science offers a pathway to achieving that vision by exploring ways to extend healthy lifespans, reduce healthy costs, very important, and improve overall life quality, the most important thing. So again, thank you to the Alliance for Longevity Initiatives for putting together this briefing with us, and to each of you for your interest in this topic. So it's really exciting, folks, and I don't know whether Dr. Oz is going to get into the blue cities, but I'd like to hear about that as well. One of them, Dr. Oz, is I have a family member from the island of Ikaria in Greece, and they're living till over 100 years old. It's really amazing, and that's not that's the rule in a lot of cases. Over 90, what have you. I know that they would drink wine and have a siesta in the afternoon, and dance all night. So that may have something to do with it. But we appreciate you very much, and I appreciate all of you for being here, and we're going to make a great deal of progress for our people. Thank you. God bless each and every one of you. Thank you.
All right. I think our next keynote speaker, well, it was originally going to be Congressman Tonko, but where's Congressman Tonko? Is he here? I don't see him here. So Dr. Oz, you're up. Thank you so much for coming.
I had him paged out of the room so I could take a spot. Diabolical, but it's effective. Gus, I'll talk about blue zones if it's okay. It's an area that I have spent a lot of time studying. My family, when I was young, we would spend a lot of time right opposite Ikaria in the Turkish coastline. And there are things that happen in these blue zones that are important for us to understand because they're applicable to this country as well. It's part of a larger discussion, but I should probably start at the very beginning. I met this guy here, Mike Roizen, who captains our America's Cup squash team, by the way, so don't be fooled by his diminutive stature. He's an icon not just in longevity medicine, but also as an athlete. And I got involved in longevity medicine at the time because Mike was so effective at describing how behaviors could correlate to longevity in ways that were measurable. And he created something called Real Age that I think treated people like adults. You know, it's not don't do this, don't do that. It's if you don't do this, you'll gain this many years of life. If you don't smoke cigarettes, you'll gain 10 years of quality life. If you don't eat meat, maybe it's a few months, depending on what kind of meat you're eating, maybe none. But that puts it into a spectrum that you can now start making decisions with. But at its very core, it's a challenge to all of us to address a problem that I'm facing and all of us have to deal with, which is the fact that 70% of the money we're spending on healthcare in this country is based on chronic illnesses that are avoidable, addressable through lifestyle means. And when I'm asked about how we're going to deal with, for example, pharmaceutical costs, the reality is the best way to consume less money in pharmaceuticals is to consume less pharmaceuticals. If you're not sick, you don't need the medications. You know, chronic medications didn't even exist when I was born. It wasn't a thing. Now it's become fairly constant because we have chronic illnesses that have grown so disparately. And you cannot have a wealthy country if you're not a healthy country. So this actually becomes a patriotic duty for people to do their best to stay as healthy as possible. So what can we do within government to help with this process? And how do we partner with leaders like those of you in this room who influence millions of Americans to think differently about the health choices they make? So I want to start off with that as a sort of a preamble and then walk you through how I'm sort of thinking about it. It is, I believe, a truism that every great society is judged by how it takes care of its most vulnerable people. and we're great people. So therefore, we have to take care of each and every one of us. And I was in Michigan yesterday with the president when he spoke beautifully about the first 100 days and what he thought was important as a message in particular for issues around health, came down to a very succinct but important comment. He said that he wants to protect the vulnerable. He wants to protect the people on Medicaid, the folks who are at the dawn of their life, which is what Hubert Humphrey said at the entranceway to our building at Health and Human Services. There's a quote from him. It says this: the moral obligation of a government is to take care of those in the dawn of their life, the young, those in the twilight of their life, the seniors, the elderly, and those who are living in the shadows, folks who have disabilities or other ailments that are chronic often in nature and going to hold them back from participating fully in society. And so when the president spoke about taking care of the poor, the elderly, and the disabled, that's what he's speaking to. And it is a promise that we will keep in this administration to make sure that those folks are addressed. To do this correctly, we have to be able to take the resources that we have as a great nation and use them wisely. So as a physician, we're all taught, how many doctors are here, by the way? Hands up. Quite a few. So one of the things we're taught culturally is to give patients the truth, even if it's not comfortable to have the conversation. That's our job. And so if you tell people things that they need to know, they'll act accordingly. So I'll just start off by saying that we are the leading country on spending on health care, something we all know. What we might not appreciate is that it's increasing our health care costs at 2% faster than the economy is increasing. So now that we're spending twice as much as any other developed country, it puts us in a bind if we're spending that much extra money. Despite all that, the number 3 cause of death in America are medical errors. And to me, another compelling statistic that you might want to resonate to is the reality that when we were all younger, 1990, the life expectancy in America was about the same as that in Europe. Can you get me a water if you don't mind? Thanks. So think about that. We were the same life expectancy as the Europeans. Now we're 4 to 5 years behind European countries. And one of the biggest problems, thanks, Noah. If I start to choke, someone do a Heimlich on me. Yes. Is there a doctor? Is there a good doctor in the house? So these numbers, as they shift, you begin to find, well, why is it that our life expectancy is dropping and yet we have an increasing amount of health expenditures? And it comes down to a few variables. One of them is obesity. 43% of Americans are obese. Not overweight, obese. 43%. In Europe, that number's around 20% on average. In Japan, it's about 5%. So we're 10 times more than Japan, where they live a lot longer than us, and we're twice as heavy, as obese as in Europe, and they now are separating from us and living about 5 years longer on average. These are all issues that are addressable, but we can only do them in a way that that includes what this conference is about, longevity medicine. But inside of that, around that, is the MAHA movement. So what is the MAHA movement? The MAHA movement, to me, is defined by one key word: curiosity. Now remember that 80% of statements are not really statements, are they? They're sort of sideways attacks, and 80% of questions are statements in disguise. So we're actually not talking with each other. And in this case, we really have to earnestly want to know the answers to the questions we're asking. And curiosity, if that's how we define the MAHA movement, has to be associated with courageousness to tell the truth about what you just learned, and hopefully do it in a way that's compassionate so people want to hear what you say. Because they don't care what you know until they know that you care. So if we do that in the right way, we'll be able to get Americans to think very differently about the opportunities they have to have agency in their future. So if we have an engaged population who realizes that it's almost a patriotic duty to do what's best to stay healthy, we have to get them the information they need. That is a fundamental opportunity that didn't exist even 5 years ago. We have tools today that can tell individuals about their healthcare situation and advice on what to do about it that's as reliable as talking to a doctor in many settings. And with the doctor's supervision and supporting that recommendation, now you all of a sudden give people very concrete action steps. You can also help them find the right physicians or caregivers. You can give them advice on how to get better pricing so they can afford to do the things that they want to have done. And all this is partnered with incentivizing clinicians, providers, to be able to give that advice and reinforce that advice. This is especially true in mental health scenarios because many people don't do what's right for them because they're suffering from underlying emotional issues that pull them back. We all know those people in our lives. Someone who's smart enough to know what to do and knows what to do but doesn't do it. And so we have to pull all that into one broad alignment of incentives, and we are trying to do that at CMS. It's part of what I believe is a holistic approach to looking at how we finance healthcare in this country. And it works because of people like you. Because individuals are fighting and pushing and knowing that there's a better way, and are going to make sure that everyone else around them knows that as well. And part of our opportunity today is to pull those ideas in as effectively as possible, hear concepts that make a difference at a societal level. I don't, and nor do any of us really want to talk about the small things. It's the big things that we should all be aligned on. And if we can tell that story and share it with the people that are in our lives with us, and then get our patients, the people who trust us, to hear that same message, then all of a sudden we go to a very different place in America. And that is at its very core why I think the MAHA movement is so fundamentally important to us being able to take care of those individuals that President Trump spoke about last night, the vulnerable Americans who desperately need our support, and every society has them. But we have to make sure that we focus on them, and everyone else gets the opportunity to be healthy without as much support. So thank you, Mike, for inviting me, for the rest of the group, Gus and the like. Who do I hand the baton to? Oh, he's there. There he is. How are you?
But actually, Mehmet, I want to ask you one question, if I can.
Is it easy?
It's a toss-up, easy. MAHA also involves taking personal responsibility. You're doing a ton of work. What do you do for your own health?
So despite the...
And I'm prejudiced because he has a great family, so managing stress is one of the most important things with posse, and so your family is that, I know.
Well, my wife says that I cause stress, but I'm not affected by it. So I sleep wonderfully, and I work at sleep. And sleep's not an accident, as you know. I'm by training a cardiac surgeon, so we are taught not to sleep. But I realize that's not such a wise way to get people engaged, because you're not as creative, you're certainly not as compassionate, you just are just trying to get through the day. I would sleep on the gurneys that brought the patients into the operating room, because that was the only sleep I could get. And we've all been there, those of us in clinical medicine. So I work on sleep meticulously. First thing I do when I get up is yoga. And I'll do 20 minutes, nothing crazy wacky. Most of it's just deep stretching. But if you don't get hot, you can't stretch well. So you have to do push-ups and calisthenics and sit-ups. And so I do those as well. If I have time, I'll do pull-ups, which is one of the best exercises, I think. And the nice thing about pull-ups is that what you ate last night has to be lifted in the morning. So you tend to eat a little less. And then I reconcile with Lisa, whatever she's mad at me about, we figure it out. It varies from day to day. She's getting her PhD in Jungian psychology, which it turns out to be quite dangerous for the spouse, because she understands all the archetypal reasons why I'm making mistakes, and she can articulate them well. And she's Mensa, so she doesn't forget anything, ever, even after 40 years of marriage. And then I go to work, and my work is very fulfilling. I love the job that I'm in, and I've loved the jobs that I've had throughout my life. And I think many of you are here because you feel the same about your tasks. But if you know deep in your heart that what you're doing matters, then it's not work anymore. There are times it's going to be laborious and difficult. That's why I mentioned that being cheerful matters to me. Because if you look for the brightness, you'll see it when it's there. You'll miss it otherwise. They did a great study looking at optimistic people versus pessimistic people. And they had them walk between a coffee house and a cinema. And they dropped a $100 bill on the ground in between the two sites. And the optimistic people found it, and the pessimistic ones didn't. And this is a true story. It says, you would not imagine it, but if you're not looking, you won't see. And that's why many times we've got 10 million receptors in the back of our eyes. All we have to do is look up, and we'll actually start to see. But metaphorically, that's what we should be doing as well. And then I spend a lot of time with people I like, and I'm careful about that, because there's this, you're going to be talking about senescent cells, I gather, today. So one of the things that's cool about senescent cells, which are a big part of aging, is that when we're young, we don't tolerate senescent cells. We're very difficult in our selection of what cells we allow in our body. We lop off the heads of the senescent cells. When we get older, we become very tolerant of senescent cells. And it turns out senescent cells are very toxic. They do a lot of bad things, right? The mitochondria is dysfunctional. They release free oxygen radicals, other chemicals, other mediators. They irritate the immune system. So by being kind to senescent cells, we're actually hurting the body. And so we have to triage the things that we're doing in life, the ideas, sometimes even the people, to make sure that we are surrounded by folks that are mission aligned with us. Thank you for asking. God bless. Thank you, everybody.
All right, and our final opening speaker. The beautiful part about longevity is this is a bipartisan effort, right? This topic space does not discriminate against political lines, and so I'm very delighted to introduce our final opening speaker, Congressman Paul Tonko.
Well, thank you, Dylan. It's great to join with everyone this morning. Thank you for the kind invitation. Hey, Congressman, good morning. Gus Bilirakis and I have worked on a number of issues together, so it's good to see his smiling face here this morning, and look forward to moving forward together. On behalf of the Congressional Caucus for Longevity Science, it's my honor to welcome everyone to our second Congressional Briefing on Longevity Science. Last Congress, I joined with my colleague and friend, Congressman Gus Bilirakis, from whom you already heard, in launching the caucus, and we're excited to continue its work. The caucus was started with the goal of better educating members about the growing field of aging and longevity biotechnology and promoting initiatives that are aimed at increasing the healthy average lifespan of all Americans. With life expectancy in the United States at its lowest in decades, we in Congress need to come together to address this decline and support science and research that will enable people to live fuller and healthier lives. The Longevity Caucus aims to do just that. I'm happy to share that there has been continued interest in this caucus, as many of you have made helping those with neurological disorders one of my top priorities for more than a decade, and work closely with the Alzheimer's and Parkinson's communities, all of whom have expressed great interest in the caucus. I also have heard from many in the cancer communities as well who are interested in the caucus. I would like to thank the Alliance for Longevity Initiatives for your important partnership and for organizing this briefing. I'm also grateful for the partnership with Congressman Bilirakis in leading this caucus, and look forward to working in strong bipartisan fashion to help improve our quality and our longevity of life, particularly in the fight against neurodegenerative diseases, with aging as the greatest risk factor. Now, Gus and I have been in many battles together, and we know we're going to fight real hard together for progress with this caucus, and using your drive, your motivation, your inspiration to guide us as we go forward. I look forward to learning from our experts today on the needs and the state of longevity science, and thank everyone for their time and interest. Now, it's an interesting time in Congress as we go forward and address the investments in healthcare with the development of this budget. And so the input from this group will be important as we travel the several weeks forward. But Medicaid is an important investment. It's been there for decades for this country. We need to use those dollars wisely. I'm a big fan of research. Let's not torture research. Let's allow people to go forward. A lot of partnerships out there with academia, with the private sector. We're stealing hope if we don't go forward with research. It should be our fundamental principle, and let's make certain that those in need, those who struggle with all sorts of illnesses, are addressed across the age spectrum with an appropriate investment in Medicaid, Medicare in this country. We pride ourselves on that, and let's make it happen. Good luck with all, and I've got to run over to caucus, but I know that Emily from my crew, Emily Silverberg, is here in the back of the room, and she will be taking copious notes to tell me what everyone is thinking, what everyone is driving forward, and again, look forward to working with each and every one of you. Thanks.
So I have a few general questions for my expert panel here. The first thing I want to ask each of you, and I probably know the answer to some extent because I've talked to you individually as many times, as, more times than I can count. But for the audience and for the policymakers in the audience, I would like you to go down the line and kind of talk about what trends in healthcare really excite you. What are you looking at in the field of longevity biotechnology, in health in general? What are you looking at as the most promising avenues that are in the pipeline? So I'll start with Dr. Kaeberlein.
Sure. So I think there's a lot to be excited about. For those of you who don't know me, I spent about 25 years in academia doing basic research on the biology of aging, and then last 3 years or so have moved much more into the healthcare technology and clinical space. So I'll speak more from that perspective now. I think one of the things that I find really encouraging and exciting is how many doctors, medical doctors, are aware of longevity medicine or health span medicine, interested in the space, and actually want to move from the reactive approach to healthcare to a more proactive approach to healthcare. And I talk to people constantly who are thinking of opening their own clinics. So I find that, and that's a relatively new thing in the last few years, I would say, how much that's growing. So I find that very encouraging. And I think what goes along with that is an opportunity for this group, people within the field who have a scientific and medical background, to align on what are some core principles based on scientific rigor that we can bring to this emerging field of what I would call health span medicine. And so I view that as something very important over the next few years.
Excellent. Dr. Verdin?
Yes, well, thanks for having me. So the thing that really excites me as a physician who ended up spending most of his career doing basic biomedical research is the idea that because of the field of longevity, we are for the first time in a position to implement a true preventative medicine agenda. Realizing that aging is the biggest risk factor for all the chronic disease of aging, the idea is by tinkering with aging, we can slow down the development of these diseases and hopefully prevent them. Not completely, but significantly delay them. That's some way, this is a concept that was advanced by one of our new colleagues at the Buck Institute, which I represent here, Lee Hood. The whole concept of P4 medicine, the idea that medicine can be personalized, predictive, participatory, and I'm always forgetting the last P, but the idea of really implementing a true agenda of preventative medicine is what excites me. And I think this could not come at a more opportune time in a way that we have a double problem, which is a rapidly aging population, which carries an incredible burden of disease. And the second one, we actually have advances that actually are pointing the way of what can be done and what should be done.
Absolutely. That excites me too. Dr. Roizen?
Three things. One, MAHA, that is the movement to teach people that all of us can live longer, healthier lives. That's what the concept of real age is all about. It's both lifespan and disability as well. That is, when you make yourself younger. You can now make yourself about 30 years younger than the average American by choosing healthy behaviors. We demonstrated you could do that with a large population at the Cleveland Clinic, 101,000 employees and dependents. We reduced our costs by $190 million a year compared to both our trend line and our competitors and the national averages by getting people to get to 6 normals. How did we do that? As John Malden would say, we bribed them, but we called it an incentive. It's the largest payment up to the allowed as an incentive payment for getting healthy. 45% of them have done it, 75% voluntarily participate. So we save $190 million. They get $1,600 each person for doing this when they achieve it. And they live, if you will, by prediction, about 15% longer disease-free. The second thing is the longevity science excites me. That is, why does it excite me? There are 14 areas of research into the mechanism of aging that have all transformed at least 2 animal species from the equivalent of human 90 to the equivalent of human 40. With 14 shots on goal, if you ask even a Toronto Maple Leaf, we care for them even though we're Cleveland. If you ask a Toronto Maple Leaf with 14 shots on goal, how likely are you to score? They would say 100%. They haven't won a, if you will, cup in a number of years, so we'll say it's 80%. What are the 3 areas that excite me most about it? It is xenorejuvenation. That isn't just getting rid of senolytic cells. As Mehmet said, as Dr. Oz said, those are not good cells to keep in your body, and in fact, there are data now that you can rejuvenate them into younger cells. The second is getting stem cells that repair us, so getting rid of old cells, getting cells that repair us. And the third one is getting rid of damaged and old proteins, as you heard Dr. Kiprov speak yesterday or the day before about therapeutic plasma exchange. But those are just 3 of the magnificent 14 areas. I think the third thing that excites me is the two congressmen who are participating here, and the group is participating in a MAHA movement that maybe we can get America to, in fact, capture the two. What that does, if you'll put up the first slide, how do I get that on? No, it's not. Somehow it's not on. But in any case, no, I see. Anyway, the point of this is it solves our problems, meaning if we get longevity and people, if you're going to live 10 years or 20 years longer that is healthy, if you do that, it solves our budget problem. It solves not only our budget problem, but if everyone who retires, the average age of retirement in America is now 61, everyone works 1 year longer, it's $340 billion in GDP. They work 10 years longer, it's $3.4 trillion, and that's for one age cohort. The longevity dividend is a huge dividend that is beneficial. There it is. You did it. Now we just have to go.
Slide.
Yeah. So if it increases by a huge amount federal tax revenue, local tax revenue. In fact, if we all do this and do it for each cohort, we actually have to reduce the tax rate to have a balanced budget. So the whole point is the longevity dividend is a huge dividend, and that is what we get. Thank you.
Excellent. Thank you, Dr. Roizen. I agree. Let's clap. So my next question, so Dr. Oz touched on it a little bit. He mentioned that the longevity science industry and effort should be at the heart or very much involved in the MAHA movement. So how do you see what's going on in the administration intersect with our field here in longevity science? Do you think they're compatible? Do you see a home for longevity science in, or do you see a home, for longevity science in the MAHA movement? Dr. Kaeberlein.
I mean, I think, of course, and I think Dr. Oz spoke on that eloquently. In fact, I would say one thing I'm also excited about was to hear somebody like Dr. Oz using the scientific terms that we've been talking about in the field for years. That's something new, and I think that's a real sign of the direction that things are going. I mean, I think, of course, the goal of geroscience or the biology of aging or longevity medicine, whatever words you want to use, is really about keeping people healthy and functional for as long as possible, which is exactly aligns with the MAHA movement. So I think we can talk a lot about, what are these specific steps that can be taken to enable that, and we'll talk a lot about, funding for research on the biology of aging, which I assume we're going to get to at some point, regulatory reform, all of those things I think fall within that category, but I see them as completely aligned.
Absolutely, me too. Dr. Verdin?
The same here. I think it's, as someone who's been involved in this field for, like Matt, for close to 20 years, I think it's incredibly exciting to see the political world getting aligned with what we're trying to accomplish. And one argument that I've made constantly, we're all searching for novel drugs, novel interventions that will dramatically increase lifespan. But one thing that is quite often forgotten by our field is the fact that we have the knowledge today to increase life expectancy by 10 to 15 to 20 years for most Americans today. And I've always been frustrated by, I am, and I'm not the only one, by the gap that exists between our knowledge and the implementation of this knowledge to the public. And I think one of the missing piece of this puzzle has actually been the political will to actually help us to implement this agenda. So I think this field is very excited about developing new drugs, and I think we should continue to do this, but I hope we will also focus on implementing much of the current knowledge to really changing the health of the American public.
Absolutely. We had a proposal called NILAR, and it was our new Institute for Longevity and Aging Research here at NIH. And we did a revision of it about 6 months after we initially published it, and we made lifestyle one of the key pillars of the new institute. And I fully agree with what you're saying. It's a combined effort, right? So, Dr. Roizen, what do you have to say on that topic?
I think the thing that I am happiest about on that topic is you saw and you've fostered a caucus that is bipartisan. If any of you have Democratic friends, we need as much bipartisanship on this issue to keep research focused, to keep the funding that we need for research in this field, including the indirect costs of it. And I think through that, and Matt, as you probably know from talking with me a little earlier, I don't see anyone better able. I know I worked with Mehmet for 20 hours a week for 14 years in writing books and columns, et cetera. And I know of no one smarter, more capable, working harder, who wants to get MAHA done, meaning to get America healthy enough so that we can reduce the costs of illness care and use that money for the vulnerable. And so the fact that you're fostering a bipartisanship is enormously helpful.
I agree. You know, aging and disease and health are something that they don't discriminate on political lines, right? We all, no matter who you voted for, no matter what you're doing, we all age, we all get sick, and we're all trying to avoid that, right? So this was a thought that the A4LI had in its inception. This issue needs to be bipartisan from the get-go. So I'm very happy we got that done too, and hopefully we can continue to add members from both sides of the aisle to our caucus. Matt, so I mentioned a little bit before NILAR, and you and I wrote, and Dr. Verdin too, we all, the beautiful part about A4LI is it's really a community effort, right? So I get input from all these beautiful stakeholders here. But Matt, you and I worked on the NILAR paper together. I think right now, you know, there's a lot of uncertainty around NIH funding, what the next steps are going to be. But let's imagine that NILAR is established. Let's imagine that right now. Let's manifest it, everybody. Let's do it together. What kind of projects would you like to see in this new institute be funded? Do you have specific projects? Do you have specific areas of focus that you would like to see research dollars deployed?
Yeah, and if I was to go through that list, we'd be here for the next hour and a half. So, I mean, I think fundamentally probably the first thing to say is that longevity research or biology of aging research has been historically dramatically underfunded. And we can go into all the statistics. One easy one I like is 9 of the top 10 causes of death in the United States have biological age as their single greatest risk factor, period, full stop. We spend 0.5% of the NIH budget on biology of aging research. So we spend 0.5% of our research budget and biomedical research on the thing that causes 9 of the top 10 leading causes of death.
And you should say we spend 70% of our illness care budget.
Yeah,
on
you're right.
those
There's all
diseases.
sorts of statistics we can rattle off. So you're absolutely right. So I think that's the most important thing. And I think within the sphere of so first of all, like, how much should that reallocation look like? I would say it should be at least as much as what we're spending on cancer, reactive care on cancer. And personally, I think it should be double or triple that. So just to put numbers on it, that's my opinion. Take it for what it's worth. So what will we spend it on? I mean, I think there's 2 broad buckets. I think we should keep doing what we're doing. The research in this field has dramatically overperformed resource allocation. And if we were to actually put appropriate resources towards that research, we would continue to dramatically overperform. And actually, I think we could make remarkable discoveries. So we should keep doing what we're doing on the fundamental causes of aging. The thing I feel like we're not doing because resources have been constrained is big discovery science in the field and let the biology tell us what we don't know about aging. We don't know what we don't know, but because resources have been constrained, that creates a hyper-conservative nature within the research community, and so we don't study those things. So that's where I would like to see, with better resource allocation, we can actually devote some of our time and energy to that.
And just to, you're saying we don't know what we don't know. I remember last year when you were here and you were at the briefing, you showed a map of the world in, I think, 1500.
500 BC.
500 BC.
Yeah, Hecates's map. You can look it up on Google.
And it was such a great analogy for, we know enough to get around and do basic things at this point, but there's a whole other world out there that we need to discover, and that's what funding will get us. So I completely agree with you. Dr. Verdin, do you have any big initiatives or research projects that you would like to see the NIA or potentially NILAR take up?
So I'd like to amplify first the point that Mike just made in terms of the status of the basic biology of aging. It is a relatively new field if you look at the rest of biology. Bona fide molecular understanding of aging really started in early 90s, mid 90s. So we're only about 25 years into a novel field of research. And the accomplishments have been amazing, but I'm convinced, as everyone is, that we have a very partial understanding of what aging is and what intervention will work. So I think I would call for a dramatic increase in the spending on the basic biology of aging. I also support the idea that this should be done by the NIH. The NIH has been an incredible tool and instrument for promoting basic discovery. I quoted the number that every dollar that was invested in the NIH in the last 50 years has actually yielded twice as many dollars in terms of economic output. So it is it's not a perfect system, but it certainly is the best system. The whole biotech industry, pharma industry in this country actually relies on NIH discovery. So there are multiple reasons why we should invest in the system. I also would call for an NIH reform in a way that I think it should be promoting more risky research. ARPA-H in some way is showing the way, and I think this is the type of initiative I think that we're benefiting from, and I think it will be instrumental in the future. So really, as Matt said, thinking about big research, high risk, high reward, these are the areas where I think the field could be accelerated, and the output will generate the discoveries and the novel therapeutics that we need in the future.
Absolutely. Fortune favors the bold, or brave, or whatever that saying is. Absolutely, I agree. That's the function of government dollars, right? We see so many great discoveries in the history of the U.S. Oh, geez. All right, we're good. All right. I didn't know if we had like a fire drill or something. All right. So, but a lot of the phone in your hand, the computer on your lap. These discoveries were funded by the government. So there's a major role for what the government can do to push this field forward. And it's the same in tech as it is in biotech and biology. So I agree with you 100%, Dr. Verdin. Dr. Roizen, what do you have to say on the topic?
Two things, I think. Whether you listen to Irina or Nir or anyone else in the last couple of days, there are a tremendous group here that need larger funding. So one is, I would say, all of you guys should get larger funding. And let me tell you the method I would use. And that is, when I became the wellness chair at the Cleveland Clinic, I didn't negotiate well. If I had negotiated well, I would have said 1/3 of the savings, $65 million a year, should come to the Wellness Institute for me to make it bigger and stronger. Instead, it goes to the general fund. I would say the same goddamn thing with MAHA. If we're good, 1/3 of that money we save with MAHA should go to the new institute at NIH for aging research. And so I think there's a way of doing that by putting it in the bill that 1/3 of the money you save goes to this institute.
I can get on board with that. That's a good idea. I like that. So we talked a little bit about the funding side, which is obviously important. Like I said, with Matt's map, there's a lot we don't know, and that's where the research dollars will make a big difference. But there are hundreds of assets in clinical development right now that are rooted in the biology of aging. Many in preclinical studies, phase 1, a few in phase 2, and we're working our way down the pipeline there. But there's a major barrier in the field, mainly that aging isn't recognized as a condition that can be targeted in a clinical trial. So A4LI, we proposed an advanced approval pathway for longevity medicine about 2 years ago. sort of in the same kind of frame as the RMAT pathway. I know there are a number of other initiatives out there focusing on fixing the FDA barriers in place for the longevity field. Matt, again, since you and I think, worked on the AAPLM paper, I'm going to start with you. What do you think the FDA could do to really make a difference and get some of these therapeutics into the hands of patients as soon as possible, providing that they're safe and effective?
Sure. So, I mean, I think there are a couple of obvious things which have been talked about. The prioritizing geroscience interventions, and I think we would need some way to evaluate what is a geroscience intervention, but if it meets that criteria, fast-tracking, prioritizing. I think the conditional approval model, which we talked about a little bit in the panel yesterday, where once an intervention has been shown to be safe, if there's a reasonable expectation of efficacy, can move forward to market approval for 5 years. I think that's an interesting model that has opportunities in this space. And then one that I haven't heard very many people talk about, but I think about a lot, is I feel like we very much treat nutraceuticals or natural products completely differently from pharmaceuticals. I would like to see a more rational, science-based approach where we really don't make that artificial designation. I think there are problems on both sides. I'd actually like to see a little bit better regulation and validation of the nutraceuticals. I think that does damage to our field, what's happening right now. And I think there are molecules out there, and I would personally put things like metformin, rapamycin, SGLT2 inhibitors, that at doses that they're being used off-label potentially are safer than some things that are over the counter. I would like to see a rethinking of the way we regulate these molecules, and maybe a path to having some potential gerotherapeutics more broadly available outside of the current paradigm.
Absolutely, absolutely. I remember hearing something about the TAME trial, for those of you familiar, that by doing the TAME trial itself, just doing the trial, we would be saving from healthcare spending in the future just with that subset of clinical trial participants. So I agree with you. We need to get this into the hands of people as soon as possible. Dr. Verdin, in terms of the FDA, what do you think can be done to help expedite the approval of safe longevity medicine?
So I want to add a few points to what Matt said, which I agree completely with. The role of supplement, because we have a large number of molecules that are potentially significant, that are sort of living in this limbo. They're not reimbursed, they're not approved, they're not demonstrated as being efficacious. So I think we really need a reform of the whole. And actually, some of them are, frankly, I do not think fully safe. So I think there needs to be a reform of the way we look at this whole supplement market. With regards to the FDA, there's been a call by some in our field for the labeling or the relabeling of aging as a disease, which this is hopefully will not be news to anyone in this audience. I'm against. I do not think aging is a disease. It is a false sort of a hope to actually facilitate the field. I think the thing that's important to know is that we do treat a lot of conditions that are not recognized as diseases, and the FDA approves medicines that are not targeting any specific diseases. The best example is contraception. And there are, if you want to do a search on ChatGPT, you will find at least 10 different FDA-approved drugs that are not targeting conditions. So labeling aging as a disease first has a negative connotation. It means that everyone past the age of 20 is actually ill, which is, when you talk about this to the general population, there's incredible resistance to this, and it doesn't paint us in a good corner. That being said, there's a situation right now where physicians, as you know, are able to prescribe medicine off-label. And we see this with rapamycin and metformin and so on, which are, have their own initial indications, but can be actually prescribed by physicians for with the hope of improving longevity. I think this is a system, but it's not a clean system, because quite often these off-label prescriptions are not reimbursed. And so this is really where I think we can accelerate the field, is by having a mechanism that allows us to identify and study secondary indications for existing drugs. And we have a slew of them that we've heard: SGLT2 inhibitors, rapamycin, Now the GLP-1 agonists, I think, are coming to the front very quickly as potential therapeutics. So we need to identify a mechanism and to encourage industry to conduct these follow-up trials and to actually have a mechanism that allow the reimbursement for prevention of disease.
Absolutely. Dr. Roizen.
I'm not a lawyer, and this is a legal question, if you will, but I was on a study section and ran one at the FDA for the advisory committee for 16 years, and helped to appoint one of the directors. So I know a little bit about the FDA. It correlates very well with the NIH. So you want to get an Institute of Aging, you need, if you will, specializing in longevity or aging mechanisms, we need to, in fact, change the patent laws so that if you're going to get back to a study of something, a nutraceutical, and give it some patent life so that the companies doing the studies, if there are, have some value. So you need that change. You then need something at the FDA where the advisory committee will focus on aging and longevity, and whether you call it a disease or whether you call it a condition or whether you call it life, you need a section at the FDA that has that as its mission, and then it correlates with the NIH. So the three of those, why do we have, if you will, Digestive Disease Institute, and why do we have a FDA panel on digestive diseases? Because they correlate together, and because the patent law fits that set of. So you need the legal way of something in patent law changing, at the same time to recognize a if you will, a section, an advisory group at the FDA on that, and to have them as the focus on it, as well as when you develop it at NIH, and the three get to correlate.
Absolutely. So I know a lot of people in the crowd in the audience right now have some meetings that they have to get to. So I want to do this. I want to have each of our panelists give closing remarks, maybe like a minute or two, and then we'll open it up to some questions, maybe let's say 3 or 4 questions max, and then let's get to these member meetings. So Matt, would you like to close us off with some remarks?
Sure. I'll keep mine very brief. I just feel so much gratitude to be here and to A4LI for doing what they're doing. I'm very enthusiastic about the momentum that's being built and what I've seen and the people I've talked to. I think we're at a hockey stick moment, and what I mean by that is we're going like that in this field. So I think let's focus on being positive, being rigorous, and being serious, because we're starting to get the attention of serious people.
Absolutely.
Likewise, I think this is an extraordinary moment. If you think about this, this is many of us who have been in the field for a long time thought that this moment would come way sooner. And actually, 20 years ago, what got me into the field, it was this incredible vision that the leaders at the time had, that we could actually change the way we practice medicine and the way we consider health. So the fact that we're here together with your support, Dylan, which I applaud, talking to Congress, aligned in principle with a movement that tries to improve the health of all Americans. I think it's just an extraordinary moment, and I hope that we keep the momentum to accelerate our field and really bring all of these discoveries to people.
You guys are making me both blush. Thank you. Dr. Roizen.
It needs to be bipartisan. So we are at a hockey stick moment, and with 14 shots on goal, I think we can get there. But we're also at a very scary moment for the funding of research. And you have a unique opportunity. Everyone here who is at the meetings has a unique opportunity to meet with 1, 2, or 3 representatives today. That's a powerful way to get the message that this will help our budget. This solves everything. It solves the kid crisis. We want to have enough workers. We're going to have people working longer if we do this well. It solves the budget crisis. It solves the Social Security problem. It solves literally our GDP problem. This is, in fact, one thing that solves everything. And you have both the obligation and the privilege of through A4LI, if you will, for you guys to do this and to get to your representatives. And to get to the representatives even if they're not on your list, because this takes a bipartisan thing. So whether it's the 1/3 negotiation of the savings or whatever you put in there, do it today and keep doing it, because this is as you said, a hockey stick moment, but it's also a very vulnerable moment for all of research.
And I will say, this is just the beginning, right? We did this last year. We're going to continue to do these fly-ins year over year, but it's not a one-off thing. Everybody in this crowd has a duty to be an active advocate for the longevity and aging field. And so I call on everybody in the audience who's part of the industry to stay involved and keep the pressure up, because this is how we get things done here in DC. So with that, let's open it up to some questions. I see Irina's got her hand up already. And you two, Matt and Eric.
Yes. Oh, yes. So first of all, thank you so much, everybody. Incredible. And I was blown away by Mehmet, Dr. Oz, understanding of our field. Totally did not expect that. So my question is about what we call scientific troubleshooting, but it has negative connotation of called negative data or failed clinical trials or experiments that didn't work. This is, in my opinion, the best thing. We can make a mistake, understand it, and that's how we move forward. So do you think that there should be a specific focus on saying that more funding should be allocated for troubleshooting in our science?
That's for you.
that's these three, not me.
No, I think this is a problem that's not really unique to aging science. I think we tend to focus on the positive. We publish our positive results. We tend not to publish or publicize our negative experiments. That being said, I think there's still a lot of inside knowledge in the field in terms of, most people know what has worked. It's just not made public in a way that is maximally efficient. But I agree with you. I think troubleshooting, especially in the whole world of drug development and drug trial, is really one area where I think we could do a lot better. Last point is, one area that I think is not being discussed enough is the way we conduct clinical trials and their immense cost. I think there is today, with the advent of omics and AI, there's an amazing opportunity in the field to really change the way we do conduct clinical trials, to reduce their cost and accelerate the way we bring drugs to the market.
Yeah, and I'll just add to that. I think I don't have the solutions, first of all, but I think it's much larger than troubleshooting or results that can't be reproduced. I think this goes to incentive structures, both in the publication world and in the way grants are funded. And we all know your paper's more likely to get accepted if you put only the positive stuff in there, and your grant's more likely to get funded. Some of that, I think, can be solved by more resources. So again, I think constrained resources within the field, and this isn't unique to our field, but within the field breed that. But also maybe some structural changes to incentivize, actually trying to disprove hypotheses or publishing negative results. I don't know what the answers are, but I do think more attention should be paid to that.
And Irina, let me just comment. With every research project, you try and reduce the costs because you eliminate some things that don't work. One of the things we should emphasize, I think, in our meetings with congressmen today are we've reduced the cost of getting the human genome. 1991 to 2001, $3 billion, now $40. We've reduced the time, 10 years to 6 hours. That's an $8,000 and a $12,000 reduction, which allows us to do science more efficiently. Nothing else has allowed us, if you will, in the government to reduce the costs efficiently. So I think it's important to emphasize the fact that scientists, that all of us in the field are efficient, and yes, you get some wrong results at times, but that's how you progress.
Absolutely.
So I think every person here probably, or at least almost all of us, would like to see a much larger budget for longevity, like 3 times what we've seen for cancer. I think this is obvious. It's not so obvious to me that as we and I think we are at an inflection point, and we're about to have a lot more money in this field, which is wonderful. It's not so obvious to me that we'll keep the same kind of efficiency and rate of return on discovery as we do this. I've seen some very large, I won't name names, but large kind of bloated companies where the innovation slows down. And sometimes operating on a shoestring budget for a startup is what keeps you creative and innovative. So as this movement gets so much more funding and budget, which I'm very excited about, how do we ensure we keep our eyes on innovation and efficiency and really push this forward as quickly as we can?
I'd love to speak to this because I think the large bloated efforts with disproportionate funding both suffer from what I think is a fatal flaw, which is the opposite of what the biomedical research world is, which is openness, sharing versus secrecy versus hiding. And I think, in some way, the basic model that this country has established, which actually has brought me from Europe to actually conduct my career here, is this incredible amount of funding and the structure and environment that promotes open sharing and discovery. And I think, this is, I've made the point, NIH is a jewel of the American government. And it stands out in the world as a model for the way how medical research can be conducted. It's not perfect, everyone agrees, and there certainly can be reform to make it even more efficient. But to me, that really should be the area of focus, because this is, look at the history. This is really what has worked and has placed this country as a leader in the whole biomedical research world.
Right here.
Hi, Keith Comito of the Lifespan Research Institute and A4LI. I think it's fair to say that if you look at polling data over the last decade or so, that the American constituency could benefit from a greater sense of agency in their health, a greater sense of hope that benefits are going to be conferred to them. So I would love it if the panel can speak about, not just at the macroeconomic level, but how advances here and how future initiatives can really inspire the American public to understand that this is going to benefit them materially.
Well, I'll take that just from our Cleveland Clinic. Each employee who hits the 6 normals gets $1,680 a year back. And so it materially, the average Medicare recipient, if you will, Social Security recipient gets $16,000, I think it's $800. It's exactly 10% increase in pay they'll be getting if they do this, while patriotically helping the whole country reduce its cost burden. And if we can get the 1/3 sharing, increase longevity research as well. So I think it's if you will, we look at it, it's a win for GDP, it's a win for the economy, it's a win for the budget, it's a win for deficit reduction, and it's a win for the individual. You'd like every individual to be motivated by just their getting healthy. I haven't been able to do it for the vast majority. That's why we pay them.
Yeah, and I think incentivizing people is great. I think also, hopefully within the broader movement, right, broader education around the impact of not just longevity science, but lifestyle factors that Eric and others have talked about, the impact that can have. I think helping people understand they're giving up 15, 20 years of high quality life. What does that mean? And I think this is a bigger question that the scientists aren't going to be able to solve on our own. It requires, I think, social structural programs that hopefully incentivize healthy behaviors and start to disincentivize, what are the current behaviors of most Americans.
Maybe it's just add one point, which is the fact that we're here in some way for us as scientists is a departure from our normal lives, and some of us, actually many of us, are not doing this enough. So the fact that the science funding is actually under threat or is being threatened by some potential harmful decisions is a reflection, in my opinion, of the disengagement from us as scientists with the public. And I think we should and we need to make a much bigger effort at communicating clearly to the public the value of what we're bringing, the potential therapies, and so on. And in some way, because of this job that I have now, I've been given sort of a podium on which to scream these things, but I think this should be something that we teach all of our junior scientists. And we've created, just as an example, at the Buck Institute, we've created a speakers bureau, which encourages all of our young scientists to come be trained and deliver specific talks and to go through our local community. And I think this is given the threat and the scare that we all live through, I think this should be a model for every academic organization in the country.
Can I just add to that? That's great, and I absolutely agree 100%. I think not only training ourselves and our colleagues in how to be effective communicators, but also how to avoid hype, dishonesty. We know this field had that challenge, and really present the optimism and what's possible in a very realistic and responsible way. I think that's going to be very important as we go forward to maintain credibility.
Agreed. All right, so our final question.
Yeah, quick comment. I think I'm Jeff Gladden, Cardiology, Dallas, Texas. I left cardiology in 2012, been doing this since then. What I've been impressed with is that there seems to be inherent resistance in the system. For example, say peptides, which were basically just banned by the FDA, or stem cells, which are tricky to use. And yet, medical boards across the states, there's resistance there. Local colleagues, there's resistance there. It would be great if in this movement, if we could have a centralized message that gets across the country and starts to remove the barriers to access. Because what we see is that with the technologies we have today, not in addition to lifestyle things, we can actually heal disease. We can stop Alzheimer's. We can stop heart disease. We can reverse many things today that there's so much resistance to us being able to get it to people freely. I think that's, as a clinician, that's kind of an important piece in all this. I'd like to get your comments on that.
Go first. Go for it.
This is a hot button issue. I do agree with you on the fact that there are likely to be interventions that are efficient, that are not approved. That being said, I think our field will only move successfully in the future by maintaining the higher standards that we have adopted in medical research and the approval process of drugs, which is we do not recommend things that are not or cannot be proven. Now, that doesn't mean that we have to spend $1 billion for every drug approval the way we have done in the future. So for me, the question is not to lower our standards and to make things available to anybody who wants them because they think that it works or their friend thinks it works, is to maintain the same rigorous standards, but to change the way we actually get to those standards. This is really where the problem is, in my opinion.
Yeah, and I would just add, I think, one of the challenges is there's a whole lot of gray area in this field. And I think what you're commenting on are a lot of things that I would put in that gray area. And the problem is, and this is, I think, what Eric was alluding to, we don't have the highest quality data to tell us what works and doesn't work. You can look at almost all the peptides that are out there. And you ask me, and I'm like, I don't know, because we don't have that data. So do we need, phase 3, hundreds or thousands of people, clinical trials to get that data? I don't think so, but we do need some mechanism where we can feel confident what works, what might work, what doesn't work. And I just don't think we have that right now.
And to get the rigorous science done, we need some, if you will, legal change in the patent to give the reward for being able to study it, or we need more federal funding to be able to study it, but we need some regulatory change to be able to do the highest science standards that Eric and Matt spoke about, because it's absolutely needed.
And I would like to advocate for exactly what you suggested. I think that federal funding to test these things where there isn't a patent life, this should have been done with rapamycin 10 years ago. Sorry, that's my pet peeve, but it should have been done. There's a bunch of stuff in that category, and that's a place where I think the federal government can have a huge impact, because wouldn't it be great to know how many of these things actually work? If we could find one, if we could find one, the economic and health impact for the American public is enormous.
Let's not forget metformin by the way, which
looks angry.
near is there. I'll just remind us. 2 points with metformin. One, the FDA approved the trial. Steve Ostad and Near went to the FDA and proposed what is in effect a aging trial. It was targeting specific disease associated with aging. So in some way, the FDA was not in the way. What has been in the way is the funding. And frankly, that experiment could have been done 10 years ago, and we would be in a different situation. And we see the same thing with rapamycin. So this is exactly the role of the government, is to actually support these trials where the economic incentives are not there for industry to pick it up. And I think I'm
Bridge the
convinced
valley
we're
of death.
leaving-
It's generic. It's the cheapest drug on the formulary, so it could be available immediately, cheaply, and making an impact.
Okay. All right. Chris was going to ask a question, but I think
So go out there and
Yeah.
get more money today.
Yes.
Get out there with your. This is what you're doing today is really important. Do it.
Yes, agreed. Knock it out of the park. All right, so with that, we're going to wrap up the briefing. Thank you all so much for joining. If you have a member meeting lined up today, Brenda should be somewhere around here. Please find Brenda. And thank you all for coming to the A4LI Summit. I appreciate you all.